Good afternoon and welcome to Reversing Lifestyle Diseases. I am KP Thompson and with me as usual is Dr. Jolly Thomson MBBS MD, who has developed the clinically supported lifestyle correction with cell activation program focused on lifestyle related diseases. Our topic is joints and arthritis and equally on joint replacement. As we all know, arthritis or pain related to the joint or diseases of the joint, there are so many in number, starting from say the shoulder pain, the frozen shoulder, spondylitis, back problems, knee pain, knee joint problems, hip problems, and so many, including psoriatic arthritis, etc. Now, commonly we find that the requirement for replacement of joints is growing. So, naturally, the question comes, why such replacements seem to happen? So, understanding these joint problems is fundamental to treating them. So, informing patients on how they should understand what are the aspects related to joints is the basis of today's life. But one thing we should know, this is for educational purposes primarily. So we should always be careful that when we make any changes, it is done under the guidance of a medical doctor. Now, to start with, Dr. Jolly, what exactly is arthritis and are there different forms of it?
Arthritis comes under two groups generally. One is degenerative. That is the most common now, what we see in the practice. That it can be osteoarthritis of the knee, or the hip, or the spine also. And even it can affect, this degenerative arthritis also can affect any joint. And next is inflammatory or autoimmune based. That is rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis. In each patient, it can be varying, different joints can be affected. Another group is the inflammatory arthritis that is not coming under the lifestyle disease as such. So we will not be discussing on the inflammatory arthritis. Next is gout, that is metabolic arthritis, gout and pseudo gout. And that is, it's an irregularity in the metabolism basically, but it is also comes under the inflammatory arthritis. So whatever be, even in the degenerative arthritis, there is a underlying inflammation. So basically, if all this having the fundamental or the root cause is inflammation. So that is what we should understand. Even though we are calling it different names, the root cause is inflammation, and it is related to lifestyle also.
See, regarding this knee issue, normally it is considered like, your knee joint has worn out, so it needs a fresh joint. So that is the common understanding. What exactly is this knee joint, knee arthritis of the knee, and what exactly should the patient understand? Because is it just wear and tear, or is it anything more?
Knee arthritis, that is most common in where I am practicing actually. And that is, I think it is all over the world also. The knee arthritis is one of the most important reason for the knee replacement. That is one of the joint very commonly replaced also with the artificial joint. Here, what is happening is the cartilage, that is the end of the bone. Actually, the bone, it's a joint. When the joint, two or three bones are joining at the joint. So at the end of the joint, there is a soft type of bone that is called cartilage. When the cartilage is worn off, or when actually this cartilage doesn't have any blood supply, when the cartilage is worn off and the because of it is doesn't have the blood supply, so it has to depend on the deeper bones to get the blood supply, and then it is getting pain when it is exposed, that nerves and the blood vessels are exposed, the patient is starting getting pain.
So, when we are talking about this osteoarthritis, what exactly is your experience with such patients?
See, that is actually in the osteoarthritis, the most common type of arthritis I am seeing. So I can give you an example. This is the 56-year-old lady. She is having around 155 centimeter height and 70 kg weight. So her problem is she had undergone a surgery of the left leg, and now she is having both the leg is having pain, and she is advised for a knee replacement of the both knees actually. And that initially she had undergone a knee surgery, that is something with the do with meniscus and all, and she's also suffering from allergy, itching, and skin lesions also there, and thyroiditis is there. She's on Hashimoto's thyroiditis, and she's taking arthritis medicine, this levothyroxine she is on, and she is suffering from chronic fatigue and always sleepy. So that is all. That is a routine problem. What is we are facing with the patient, and they will be finding it difficult to walk or sitting up, getting up from the sitting position, or climbing stairs. All are the usual problems. When we looked into actually her, many of the nutritional deficiencies are there. Basically, I am working with this this lifestyle correction to see whether the patient is any deficiency, or whether the patient is taking commonly using food is intolerant or allergic. All these things we take a detailed blood test, and she's vitamin D is deficient, and folate is deficient, and even magnesium is a lower level. Dyslipidemia, that is cholesterol and triglyceride is high, ESR is very high, and but the usual this RF factor and anti-CCP and all is negative, and ANA is also negative. So it is not coming under the this autoimmune disease. But the AMA is high, that is ANA is normal, that is not in the SLE group, but AMA and anti-TPO is high, that is because of the thyroiditis. And then we look into and she is also pre-diabetic also. She was not knowing that her HbA1c was 6.1, pre-diabetic only. And then what is the result? Actually, when she has already undergone a surgery and now knee replacement is advised. Actually, within 2 weeks itself, she is finding it comfortable to walk. And by 30 days, she came down from, her weight came down from 70 to 65. So by the time she is okay, and even her itching and discomforts are gone, and she was able to actually by even the thyroid hormone, the replacement is able to reduce. Actually, by day 60, she was able to come down the thyroid hormone level to 20 from 100 to 25 milligram. So that is the result actually. So it is in the clinically supported lifestyle correction, we are not treating each disease. Actually, it is the person or the body we are treating. So that is why we are we are using the repair capability of our own body by giving optimal nutrition and optimal exercise.
Actually, when we are talking about pain in the knees, what is happening is, the patients who have pain in the knees, They also have pain in the hands, joints. So knees we can understand, as you said, no, because of weight, walking, that wear and tear and all that. Hand joints and all also are having the similar problem. So what happens when a patient has knee point problem as well as hand joint problem? Then how can this lifestyle correction and all that? How does that work?
Yes, definitely. For the osteoarthritis knee problem, we can think that there is wear and tear. But we should remember that those who are living in the flat and not doing much work is the most commonly getting osteoarthritis. So it is not just the wear and tear or not with just the weight. It is usually in the excess fat. What I am seeing is even the patients coming with the osteoarthritis will be definitely may not be obese but overweight. At least even if it is in the normal range, their fat content will be more in the body. From the fat, there is some certain inflammatory markers or inflammatory agents are coming out. That is IL-6, that is interleukin 6, or leptin, that is a hormone coming from the fat, and TNF-alpha, and so many items. We don't have to go into the details. But the focus of all the new treatment is the latest biologicals and all is focusing on that. Then how this what will be the in the clinically supported lifestyle correction or with the CSLC cap, what is the benefit is, it is not only if you replace the or you do the surgery and replacing the knee, you will the hands problems will be continuing with that. I'll tell you a patient, an example, who's having osteoarthritis and also osteoporosis and osteoarthritis of the knee and also the joints and with deformed leg, toes and the fingers. And this is a patient with 158 centimeter and her weight was 84 kg. See here the weight, it's also high. And so she's in the her BMI is around 34. And when we are looking into the fat level, she's having 44% fat, and the visceral fat is around 20%. So the excess fat is there. So with the clinically supported lifestyle correction, in the clinically supported correction, we are not trying to reduce just the weight, actually to reduce the fat and build up the muscles. So the muscle is acting as a shock absorber, especially for the knee joint and all. So it is equally reducing the fat and increasing the muscle is very important. And only if she's having osteoporosis also, only if her muscle gets stronger, only her osteoporosis problem can be also get corrected. And within usually we give active treatment for the 3 months. And I'm not going to the blood report on the details of her. And she had other varicose vein and she had done varicose surgeries and all. I'm not going into that. And what has happened is actually within a month itself, she's symptom free. And she was within 3 months, she was able to come down from 84 to 73. And her fat percentage come down from 44 to 40.2, and visceral fat 20 to 13.5. See, that is the difference. So by the time her finger problem is over and her knee pain and all is gone, she is able to move freely and walk, climb stairs. Otherwise, that she was also advised for the knee replacement surgery. That is the only alternative if she want to walk freely.
Actually, when we are talking about this joint pain, what is it that this rheumatoid arthritis also shows typically all these sort of joint pains and all that, and at the same time, the feeling is it is quite different from this osteoarthritis, but the impacts seem to be very similar because the pain and the inflammation and all that seems to come together. So In the case of osteoarthritis and knee replacement situations and all, you were telling about this lifestyle, how corrections can help in that. But what about rheumatoid arthritis?
See, in the rheumatoid arthritis also, the problem is basically inflammation. Here, the joint capsule, the other place, it is the mainly the cartilage was attacked. But it is in the latest study shows that in the osteoarthritis also the bone and the capsule also is getting affected. In the rheumatoid arthritis, in the initial stage, the bone capsule is the mainly attacked, and it is basically autoimmune disease. So we'll, with the clinically supported lifestyle correction, the approach is same. Basically, we are correcting not the joint alone, we are correcting the body. I'll tell you an example. This is a lady, 39 years only, and she's suffering from rheumatoid arthritis for the last 10 years, and she's on a rheumatologist care. And she is getting many medicines, she's getting reactions like HCQ, she's on HCQ, and when she's coming, she's on HCQ and also iguratimod. And she was on tofascinib also, but she was not able to take it because her liver enzymes were going up. And she was tried the methotrexate, that also she cannot tolerate. Even with this 10 years, she's initially from onwards, she's on medication from the rheumatology care, but she's hands are all deformed. Actually, it was soft, not fixed, but the deformity was there, and she was not able to even grip to hold a glass of water. That was the situation. And even with all these medicines. And in that stage, when she came, and when we looked into, definitely there is this RF factor is very high, anti-CCP is very high, ANA also is very increased. And all the inflammatory markers, ESR 116, HSCRP 28, CRP, even insulin level, hyperinsulinemia is there. And she was not that overweight, only 160 centimeters and 63.4 kg. Then what is the result with the clinically supported lifestyle correction? We are giving the patients the correcting. We are focusing on the body is give optimal nutrition, optimal exercise, minimize toxins, and improve the immunity and make an atmosphere for the body to correct or repair itself. With the clinically supported lifestyle correction, within a month itself, she was able to become comfortable. And by day 120, she's out from all the medicines she was taking. That is the importance. We cannot stop the rheumatoid arthritis, this DMR, these medications, we cannot stop just like that. We had to reduce with the symptomatic improvement and the inflammatory markers and the autoimmune markers can reduce the medications. And by day 90, sure, CRP and HSCRP are came down, but RI factor and anti-CCP was reduced but not came down to normal. But she's having it symptomatically much better, and also she was actually by the 120 days, you saying that she can even do the push-up. So that is the muscle strength is also coming. Otherwise, no one can do push-up like that. So that is the importance. And she came down from 63.5 to 56 weight. Only that fat reduction only we are concentrating, and she is from the 36% fat to she come down to 31. That is the change in the body parameter.
Actually, when it comes to elderly patients, they commonly we see that they will be having this joint pain, then they will have an element of rheumatoid arthritis, then parallelly they will have something problems with respect to lungs and stomach, and everything will be even commonly diabetes and all that. So there will be too many different issues. So when such multiple issues are there, what is it that you uh, see is very important when managing such patients, and what can they expect from clinically supported lifestyle correction?
Yes, multiple diseases. Basically, old age, when you are becoming older and older, there will be many diseases, not a single disease. Usually, what we see is for the heart, will be cardiologist will be there, or the diabetologist will be seeing, and if you have arthritis also, if the rheumatoid arthritis, then you are dealing with the rheumatologist, and if you have osteoarthritis, then the orthopedician is the one who is doing the knee replacement. So I can, this also I can tell you from my own experience. One patient, she's a 72-year-old lady, 153 centimeters and weight 60 kg. She is suffering from diabetes for a long time, 25 years diabetes, and she had a stroke. Asthma medicine is there. Rheumatoid arthritis for the last 4 years, and she is on multiple medications for the rheumatoid arthritis, asthma, stroke, and cardiology care is there. Fatty liver is there. All these medicines may be the reason she's having gastric problems also. And she was on this antiplatelet agents, clopidogrel, HCQ, methylprednisolone, methotrexate, folic acid, and diabetic medicines, this cardiac medicines, and so many. I'm not going into the details of the medications. And finally, actually, she's coming to me at a stage where she was not able to sleep because of the pain. And the doctors advised that only way is knee replacement. And she is in this age, and actually the family, many from medical professionals are also there. They understand that she's not able to have a knee replacement surgery and all, because you cannot tolerate that. So that is why they are tried. And with that, actually, with the clinically supported lifestyle correction, she also was able to come out of her medications within a month itself. Actually, the only thing that we continued is, because of her old age, we are not sure that she will do the exercises properly. That was, she has a memory problem also. So continuous caretaker is not there. So we continued this antiplatelet agent, because if she is missing exercises, then the clot formation and this stroke possibility is there. Except the this blood thinners, she was able to come out of all the medicines, and she was able to, the most important thing is, she was not able to sleep, but by the time 3 months, she was able to take over the kitchen work also. So that is the importance. Here, the clinically supported lifestyle correction, we are focusing on the whole body. So the repair, what if you give the proper nutrition and the proper exercise which the body can tolerate. This lady with pain, she cannot tolerate too much of exercise or anything. But if you are able to teach them the correct exercise mode and correct food pattern, then they can repair. The body has the capacity, there's a tremendous capacity to repair. That is what we are not really using in the modern health practice.
Now, very commonly, we see this frozen shoulder. And also, earlier and all, it used to be something that was a problem with elderly people, or some those who are doing very strenuous workouts and exercise and physical work and all. but now the lower age also the adults are getting frozen shoulder. And also there's some sort of a linking of this diabetes, high glucose, and frozen shoulder. What exactly is the situation?
See, here also, it is this frozen shoulder is so common here. And most of my patients, they're not coming for the frozen shoulder alone. They'll be having diabetes and other or Hashimoto's thyroiditis, obesity, and all will be there. Multiple problems will be there, not just for the frozen shoulder they're coming. The frozen, it has actually, there will be a painful stage, then a limitation, and then it can resolve in many patients. It can comes out resolve also. So they take some anti-inflammatory agents and move like that. But the difference in the with the clinically supported lifestyle correction can be explained with the patient example itself. This is a 57-year-old lady, 163 centimeter height and 74 kg weight. She's suffering from varicose vein for the last 30 years, arthritis, and this joint problem started actually for the last 5 years. And she had undergone 2 surgeries already. Arthroscopic surgery for some knee repair has already done, and she had undergone a carpal tunnel syndrome surgery because of her muscular wasting of the hand, and both the hands actually has done. And her when it's already the neuropathy is there. When she came after the carpal tunnel syndrome surgery, also she was not able to do any work, and she cannot even hold. It is also in a very but this the palm muscles also is very wasted. And she had other problems like knee pain, shoulder pain, disc prolapse. In the MRI, disc prolapse is there. Again, skin lesions also is there because this varicose vein and the leg there is itching and problem. Vertigo is there. So there is so many problems. Usually that is the pattern we are saying. And in blood checking also, her ESR was very high, 107. And some other nutritional deficiencies and cholesterol and triglyceride is high, and such things are there. And also when you look into the her allergy and intolerance pattern, she is allergic to many of the commonly used food, even including the rice. Such was the situation. And her IgG level and IgE level was very high. And then we see what was the result with the clinically supported lifestyle correction. See, by the within 3 months, she was able to come down from 74 to 62. That is the result. Usually, the patients will be able to, if they are following correctly, this patient is following very correctly, and she is 10 to or around 10 to 20%. Generally, around 15% weight reduction in 3 months is the pattern. And weight reduction here again noted down, that is the fat reduction. Her fat level was 38.4. She came down to 32%. And visceral fat also 10% to 5.5. That is the difference between the regular weight reduction and in the clinically supported lifestyle correction. By the time her pain and problems were over, the shoulder pain is gone, but the degeneration of the nerves was already happened, which we cannot, but his grip has improved, but it is not completely corrected. So that is very important, that if you have a weakness of the hand, or even the carpal tunnel syndrome and all, if it is corrected early, she will not have lost her muscles. And the neuropathy, we should, one important message from this patient's experience in telling is to correct it early. Don't wait for the last moment. And if before the carpal tunnel syndrome surgery itself, if you can even avoid such surgeries, if you are willing to correct the lifestyle early.
Actually, now it's very common for relatively young adults to have disc prolapse. And after a couple of years, then it becomes spondylosis. Actually, because of the current situation of many times we hear that it is because you have ridden a two-wheeler, this is happening, or something or other is the, it seems to be uh, becoming more and more common. At the same time, since it is happening at a relatively early age, there is always a fear of surgery. If surgery has to be done at the age of 40 and all that, then their active life may be affected. But at the same time, this pain is coming once in a while, but at that time they are not able to perform their functions well. So in such a situation, what is it that is normally possible? What is your experience of this?
For the back pain, and it can be both, it can be of inflammatory type like ankylosing spondylitis, or this disc prolapse and disc problems, that is comes under the degenerative problem. Both of this can be, this lifestyle correction is a very important role in that. Even in the with the disc prolapse, if it is for the disc prolapse, if it is affecting the nerves, like if the patient is feeling numbness in the saddle area, or if the pain, severe pain along with the numbness, and even in the to the hand, then there may be the nerves may be pressurized by this bulge. So in that case, the surgery is essential. If the pain is severe and there is neurological deficit is there, definitely immediate surgery can save the nerve. But if even though there is bulges there in the MRI, and but the pain is only moderate, in that case, definitely the lifestyle correction and the exercise and correction is very much useful. But the exercise we should be very carefully done. If you are lifting weight or too much of jerky movements, it can actually aggravate. Gentle, we actually in the clinically supported lifestyle correction, we usually very gentle exercise in the lying or the sitting position, and give optimal nutrition for the repair of the disc. And in the ankylosing spondylitis, it can come in the younger age, in the late 30s or the early 40s. And there also can be, both can be going together also. If there is some degenerative changes in the disc alone, that and also that ankylosing spondylitis, like bone formation and inflammation evidence will be there. But whatever is the problem, in my experience, what I am understanding that your body has a capacity to repair, provided you give the correct raw material for the building of the body. Because every minute, every second, our body is changing and the new cells are coming, the old ones or the damaged ones are replaced. When you are giving the correct fuel or correct raw material, the body can make this damaged cells, inflamed cells, can be replaced with the new cells. So you need a method for this, and that is what actually we are providing for our patients. Like the scientifically guided atmosphere for correcting the body composition and the correcting the biology itself.
Actually, when it comes to this knee pain, what exactly you feel is the patient should know about, what is the most important part of treatment?
See, internationally, in the arthritis, especially this degenerative arthritis, the first line of management is lifestyle correction, exercise and weight reduction, and not just weight reduction, it's, as I said, along with the exercise to build up the muscle and reduce the fat. That is the standard treatment in all over the world. It is the thing. If you are not able to correct it, then that is the reason for it is progressing. If you are not able to correct the lifestyle or reduce the fat level, then the inflammatory chemicals are coming out of it and it is damaging the your joints. So the simple thing is to correct it in a meticulous or a structured manner, and that is what the patients are not really getting support. So a structured lifestyle correction is the real answer for this, the solution for this sort of, even if it is osteoarthritis, ankylosing spondylitis, or rheumatoid arthritis. With that, you can correct any of these arthritis problems to correct the metabolism and correct the biology.
Actually, you are saying about this weight reduction, no? How much, say, when a person is asked that, or told that reducing weight will help in such a condition, what is it that he should know? Because how much weight can be is needed to be reduced and all that? Because, persons who are overweight, their biggest challenge is reducing weight.
Yes, there are on the weight reduction, there are studies shows that if you reduce 1 kg, actually the strain on the leg is equal to 4 kg reduction. So that means if when each step, if you reduce 1 kg, the strain of the leg is reducing 4 kg with each step. So you are making how many steps a day? So if you are reducing 5 kg, by the time it is 20 kg, weight load is reduced from your leg. That when you are, that is actually we are also applying that. That is the reason the patients are getting very fast result. And most of the patients, 2 to 3 or even 4 kg weight reduction within a week, actually, we are getting. Why? Actually, that it is not that the fat alone. In the initial stage, there will be inflammation and the body edema and all will be there. So within a week itself, they may be getting 2 to 4 kg reduction. And by the time the patient comes in the 8th day itself, there will be much difference will be there in their performance. And usually within a month, those who are able to not walk properly or not able to climb steps, they can be able to do those things. That is symptomatic relief. We think that the lifestyle correction, you won't get, it's very difficult to get symptomatic relief. But we use, if the patient is painful, definitely we are using the anti-inflammatory agents also. So if the patient is painless only, we can do the exercise. So make the initial stage, we'll give NSAID or whatever anti-inflammatory agents is given, and then the patient may be in many of these medicines, and then come down, taper off the medicine. That is what we are for.
Actually, in this weight reduction programs, normally what we see is, the patient, you were saying that just reducing the weight itself is not enough. Their their strength should be there, and also we hear that, their body composition should be corrected. The omega 3, 6, 9, etc. ratios should be corrected and all that. So people, how in general, how is it that they can go through this? Because when we go to a normal medical facility, the primary usually the primary thing that matters is what medications are given. So with these medications, or can you reduce weight, or with these medications, can you build up muscle, or with these medications, can this omega 3, 6 ratio and all be corrected? How is it?
See, with the medicines, whether you do we have medicines for weight reduction? Definitely is there. That we will discuss in the medication for the weight reduction. We will discuss in another episode. But here I'll tell you about the arthritis point of view. In clinically supported lifestyle correction, weight reduction means correcting the lean mass fat mass ratio. It is not just reducing the weight. We are trying to reduce the fat and increase the muscle and bone mass. That is, lean mass should be increased and fat mass should be reduced. So in the nature, there is everything has a proportion. Even the oxygen, carbon, and such things, that there is a proportion in the water content in the body. Actually, around 65% of oxygen is there, and around 70% of our body is water. When you are building up the fat, thing is the carbon is increasing and the oxygen content is going down. And similarly, when the fat is increasing, your omega-3-6 ratio, actually the fat, there are 4 types of fat, but this omega-3 and 6 is the crucial. They act as vitamins, and actually they are the controllers of immune system itself. Inflammation is a part of the immune system, and this healing, that also is part of the immune system. Actually, this bodybuilding and repair and all is under the control of the immune system. That is, the defense part is the inflammation, and the repair part is the anti-inflammation. We are focusing on IL-6. Many of these modern medicines and the biologicals are actually focusing on the interleukins. Interleukins actually is made from the omega-6, and there are anti-inflammatory things like other this C20. Actually, we say it in the research aspects. It is so C20 carbon fatty acids, and its metabolism actually that is the fundamental of this inflammation, and is that fundamental research evidence is using in this clinically supported lifestyle correction pattern itself. Actually, most of our modern medicines are focusing on this omega-6 fatty acid metabolism, and omega-6 fatty acid suppressing the omega-6 metabolism. In this clinically supported lifestyle correction, what we are using is decreasing the omega-6 itself and increasing the natural counterpart of omega-3, that is anti-inflammatory. And by increasing the omega-3 in the body at the cellular level and reducing the omega-6, that is inflammatory, at the cellular level, is the basic principle in this. And not only just reducing the fat, reducing the omega-6 fat in the body and increasing the omega-3 fat. That is actually the basic principle wise. It is actually correcting the lean mass fat mass ratio one side, and also omega-3-6 fat mass ratio, omega-6 fatty acids ratio in the fat itself.
So if a patient is obese and has arthritis, what exactly would you like to see the patient progressing towards?
See, obese patients with arthritis, I'll tell you an example itself, with a patient example. This is a patient with height 176 centimeters, and his weight is 98 kg. And he is having difficulty in walking, and he has to use in the airport and all for the wheelchair is a necessity, and find it difficult to climb stairs at all. So that patient, actually, when he came, and he had some urinary problem, prostate problem also. And otherwise, he has diabetes, no hypertension. But in our experience, this detailed investigation, he has many nutritional deficiencies, vitamin D, B12, magnesium, etc. was low, and also some kidney function low. And when you come to the another thing is his PSA also was very high. It was 11.4. So in this patient, when we corrected, and actually this urology side, he was asked for a biopsy and the prostate biopsy, And in the orthopedic side, he was asked for the knee replacement. In that stage, actually, he's coming to me. And when we started the lifestyle correction, and that time, even though the immediate concern was the PSA, actually, PSA came down from 8th day itself, 8.89, then came the 15th day, it came down to 7, and then it came down to 6, and by the 30th day, and by the 60th day, it is PSA has come down to 3.7. So that is the result for the PSA, because everyone is worried about the cancer, no? So it was actually again in the 90th day, it was only 3.6. It is the safer level. But we will definitely follow for a long time. Once the PSA is high, we had to follow it for a long time. And what about his weight? Actually, his weight came down from 98 to 75 within 3 months. No, 4 months. By 98 to 75 in 4 months. So, and his fat level, he was male and his fat level was 31, it came down to 22. And visceral fat was 21.5, it came down to 11. And by the time prostate size also reduced, not only the PSA reduced, prostate size reduced, his all the urinary symptoms was gone, and along with that he's able to walk freely, and he doesn't need he was actually from outside patient, and he was happily telling that now I don't want a wheelchair I don't know how to request a wheelchair in the for the flight.
Actually, nowadays, for generally, the feeling is that, in case we have a cardiac issue or some metabolic issue like diabetes or hypertension and all, the general advice that is given is, walking is one of the major solutions for that. But at the same time, all these see, in all these situations, invariably this joint pains also come. Movement is difficult or painful and all that, and especially sometimes the knee itself will be the problem. So in such cases, how can they manage?
See, multiple health problems, especially obesity, arthritis, and many of them will be having cardiac problems or diabetes or hypertension, and such multiple health issues will be there. I can tell you one example of the patient itself. So it is will be more what the patient people can understand. It is easier with an example. So I'll give you an example of a patient. He is actually 176 centimeter and 95 kg, and is diabetic for the last 13 years, hypertension 16 years, and cardiac, he had an angiogram and had a stenting 2 years back, and now again heart problem, TMT positive, and again angiogram, it shows the 3 vessel disease, and he was advised for a bypass surgery, and he is having knee pain, and he was also told that he has to undergo knee replacement. That's the only option. And when we looked into that, he is having so many medications also he is taking for the cardiac problem and diabetes, insulin, and also tablets like glimepiride, metformin, leptin, and again dapagliflozin. So 4 tablets and insulin, degludec, insulin injection. It is insulin or okay. That is one injection and 4 type of tablets is taking. Even though with all these medicines, his HbA1c was 8.7. So other deplat, acetor, amlodep for BP, verapamil for BP, and I'm not going into all the medical names actually. then actually what happened? What was the result with the clinically supported lifestyle correction? So when we looked into his C peptide is normal, so it's around 4, and the insulin level we don't consider when a patient is on insulin injection. Insulin level is not that very important, but he had a very high insulin level, 77 actually. And even with this statin and all, his cholesterol level was 289 and triglyceride also high. And homocysteine and HSCRP level was also high. So with the clinically supported lifestyle correction, if the patient is type 2 diabetes and the insulin body can, C-peptide level is normal, usually initially it's to stop the diabetic medicine. Otherwise, when we are giving a low carbohydrate diet, otherwise patient can get a hyperglycemic attack. So usually within 24 hours itself, the patient will come down and the sugar will be normalized. Reasonable in the limit of normalization will be there within the 24 hours itself. And if it is the high sugar is going high, but usually with the meal. In that case, we use this gliflozin type of medicine, which this excess sugar is passed to the urine. And within a month itself, he was actually able to come out of all the other medicines also. And with the cardiac markers is coming down, we can even if the patient is doing the correct exercise and all, the food is corrected, even the blood thinness can be reduced only with the cardiac markers has to come down. And this patient within 3 months he was actually able to, from 94 to he was able to come down to 77. So with that is the difference. So actually, he was telling that he has gone to the trekking in the Himalayas also after 4th month or so. So that is the difference. Actually, he was advised for a bypass surgery and a knee replacement, but he was within 4 months he was able to go for a trekking trip also.
Sometimes we find that those who have these joint problems like this, either degenerative like osteoarthritis or autoimmune like rheumatoid arthritis, invariably, during the course of time, because of this immobility and all that, they start putting on weight, and for different reasons. So in such cases, when these patients, how is it that you can explain to those who are thinking about it in this way, that they have to, they would like to reduce weight because everyone says you should reduce weight, but at the same time, they have mobility issues, so they find it difficult to reduce weight. So in such cases, what is it that they should understand?
See, arthritis and obesity and weight reduction is a common thing what we are seeing. This arthritis patient will not be that the common exercise we advise is walking, and there will be because of the painful this knee or the ankle or the even this the back pain, and all will be there with these patients. So this clinically supported lifestyle correction, that is SLC CAP, is designed for the patients. That's why we are advising only this exercise in the lying or the sitting position. And here also I can explain with the patient example. This is a 48-year-old very young lady, 158 centimeter height and 79 kg is the weight. She's suffering from arthritis for the 16 years, and then she got psoriasis also. For the last 8 years, she's having skin lesions. That is the pattern actually. So autoimmune rheumatoid arthritis, sometimes it comes first this other psoriasis, or and also she was suffering from the thyroiditis also. She's taking both 3 autoimmune diseases, we can say. or we can say that it is psoriatic arthritis, and also now she's having rheumatoid osteoarthritis knee also. In such a patient, and with this obesity, and what we actually, she was on methotrexate, folic acid, tofascinim, Defacort, and some ointment for the skin problems also, that is steroid ointment. Since Defacort and all is steroid type of medication, it is the non-complication is the weight increase. This patient actually within when we gradually we go down with the medication and with the weight reduction also. Actually within a month itself she was able to reduce her skin problems was almost settled within a month. But by the time actually her weight reduction, usually many of the patients weight reduction is very fast, but the problem is a long-term steroid patient is very difficult to reduce weight. If it is not on the weight put on with the steroid, it is very difficult to come down. But she was able to within 3 months, that is why actually within 2 months she is only able to come down to around 5 kg, and then by the that is actually her thing, but she was able to come down by the medications was stopped by around 2 months itself. Even though she was able to get the only weight reduction 5 kg, but by the time usually many of the patients get 10 or 12 kg. That may be one of the reason, but there are people who can reduce the weight even though they are on steroids, but some people it will be difficult. And this patient, the osteoarthritis pain and the rheumatoid arthritis pain, it is gone, and also but it is this rheumatoid arthritis, the one thing is that if they deviate from the lifestyle, or there is a stress in the family or stress in the workplace or an infection, it can reappear. So we should, even though we come out of the medication, then again there may be finding out the remission, this recurrence early, and stop it in the early stage itself. That also we are always there will be kept medication, anti-inflammatory medication should be there with this sort of patients, especially this rheumatoid arthritis patient.
What about patients who are on the elderly side? Very commonly, they seem to have some sort of bone strength loss or something, and the limbs get curved, and then they also have muscle loss, and everything comes together. So at that stage, normally they usually will be not very keen sometimes on going for surgical correction and all that. So the bone is weak, the muscle is weak, and the deformity has been formed and all that. Yeah, such elderly cases and all, what exactly can they look forward to?
The deformity of the knee is very common from the early stage itself. So if the patients, they're even without, they may not be having pain at all. That time itself, the joint can be varus deformity or valgus deformity. The knee is going away from each other or coming together. So this both the type of deformity we can see, and also if you notice your leg fingers, especially the toes, the toes can be deviation of the toes can be noticed, and many of the noticing the finger deviation, it may not be that easy, but the toes deviation also can be even without the pain or the symptoms. So I can tell you an example. For when it comes to an elderly and bow leg sort of thing, it is elderly and much of the deformity. It is even the surgery will be difficult. It's a 72-year-old lady, and her height is only 141. Maybe because of the bowing of the leg, it is reduced. Maybe she must have a little more taller. And her weight is 70 kg. And she could not get into car. Yeah, because of the deformity, she cannot get into a car, and so she was actually brought in the ambulance, and but she can walk with the walker. That is the plane level ground. She can walk with slowly with the walker. That is her situation. Actually, the result was actually she was not diabetic or hypertensive. Only thing her inflammatory markers, ESR, HSCRP, even the WBC count was high. Many deficiencies, vitamin B12, actually B12 was very low, vitamin D was very low. Early stage 1 renal problem was there, and homocysteine was very high. That is also very common with these nutritional deficiencies. And what was the result actually? She came in the ambulance and with the stretcher, but within a month, she was able to get in, reached a stage in which she can get into a car, and she can lose this walker is not needed, but he can need not only a stick stage, but limping was there. And by day 90, her weight came down to from 70 to 56. Here, that the importance is what I noticed was the caregivers were so caring, and she was their absolute care they were giving. That is the reason for her improvement. And by the day 150, that is 5 months completed, her weight came down to 46 and her BMI is 23. So she came down to a normal BMI. And when she came, her fat percentage was 48.4, and this came down to 35.8. And visceral fat was 24.5, and it came down to 7%. And this all the inflammatory markers came down, and even the ESR, every inflammatory markers came down. Even she was in the early stage of stage 1 stage, her GFR was low. It was also increased to 87. So that is the condition. Even in with the old age of this 72-year-old, with all this deformity and difficulty, the body's repair capacity is there. That is, we are not utilizing it in the proper way. So that we should understand that we have tremendous potential in us and use that.
You often say, that medical care and healthcare are actually, two aspects that generally patients and their guardians should understand. So, if we are talking about this joint pain and arthritis and all that, what is it that we should understand with respect to what is medical care and what is healthcare with respect to these issues?
See, medical care, when you have a problem, you approach a doctor and you are getting the relief from it. That is when you get pain or discomfort only when there is inflammation, or you have to get a wound. Wound also, it is inflammation is the part of when say if you get an injury or wound, there is also inflammation. So almost all the medications, which is all the surgical procedures, everything is focusing on even the correcting is also we are preventing the you're giving medication for that. That is the purpose. When it's for the medical care is for the immediate purpose. That is definitely essential. If you get a wound, you may be giving the anatomical correction, bone fracture, you need that, or you get a infection, you need antibiotic for to that is also helping the body to come get rid of that problem, that is the virus or the antiviral or antibacterial. That is the thing. That is what is medical care. In the healthcare, what is healthcare? Healthcare is comes after that or before that. When you are in the sick, you need medical care. But you can prevent. Prevention is through the medical care. And definitely that this vaccination and all is there. That is also comes under this any medication or vaccination and all comes under the medical care itself. But your lifestyle correction is the real healthcare actually. That doesn't have any side effects. if you are doing it in the correct way. If you are doing it in the wrong way, your nutrition is not correct, you just trying to reduce the weight alone, that can create problem. But you are doing in the correct way with the optimal nutrition, optimal activity, optimal rest, and reduce toxins. That is the four major aspect of this lifestyle correction or the healthcare itself. And if you are doing if you are in pain or any problem, definitely medical care is very important. But when you come out of the struggle, then you can, if you use the healthcare aspect or the our modern understanding about the healthcare and the biology, you can come out of the medication itself. With the 90% of the medications we are using for the mainly for this lifestyle related diseases, even the surgeries are like that. And if you use the healthcare aspect, you can reduce the medication use and also surgical interventions.
Regarding this arthritis, that is joint issues and all that, another severe sort of difficulty quite a few people face is gout. So, what is it when we are talking about this joint pain? How does gout fit inside it?
The gout is a sudden, usually gouty attack is actually sudden pain, usually the base of the your great toe, and other areas also it can come. And basically it is the deposition of urate crystals, uric acid actually, uric acid crystals, sodium urate crystals is depositing inside your joint, and it will be giving a sudden pain. And usually it is after the high protein meal or an alcohol or some triggering factors will be there. These patients who are prone for this gouty arthritis, if they get take alcohol and have a heavy non-veg meal, then they may get up with a severe pain in the night itself. So that is one aspect of the gout. And here, even with the uric acid level, when it is normal itself also, they can get it. And now latest studies are showing that that is also an immunological mechanism problem. There is called this necrosis and all. I'm not going into the details of that. I'll give an example of a patient who's having gout. Actually, it's a lady of 58 years and she had four attacks, so episodes of gout previously. And when we looked into her details, actually her GFR has come down to 37. So anyone who is having a high uric acid is a waste product of the protein metabolism, and if it is increasing in your body, it should be considered as a renal problem also. And when she came to me, actually she was worried about, she was thinking only about the gout. But when we look into, she was pre-diabetic, and also her cholesterol and triglyceride level was high, and GFR only 37, and cardiac markers also, and some inflammatory markers high, and also she was thyroid. It was there, thyroid problem was there, Hashimoto's thyroiditis is there, and this TPO was 1300 and AMA 487. And after when we treated, see, if the GFR is gone down or the kidney function is gone down, especially actually she was under most probably her kidney problem may be because of an this IgA nephropathy. She was the nephrologist asked for after diagnosing this, asked for a biopsy, but she didn't go for that. Even though with the diagnosis, the treatment is not going to change, man. And what I can tell you, actually, she after 4 years, she's under care for the last 4 years, and at that stage itself, we are able to maintain her GFR around 40. That is the thing, even with the 40 this years. And her actually this her thyroid problem, she's within 3 months itself she was out of thyroid medication, and even her ATG and TPO level also is come down to normal. It is very rare. Actually, antibodies, to bring down the antibodies is very difficult. Even the thyroid function can be corrected easily, but in many patients it is difficult to bring down the autoimmune antibodies. That is applicable in the rheumatoid arthritis also. Symptomatic relief will be there, but the autoimmune antibodies will be present there. Actually, for the last her follow-up visit, anti-TG was only it was anti-TPO. Actually, anti-TG was only 31, and AMA was come down to normal also. And thyroid function, without thyroid hormones, she's having a normal thyroid function.
Something related is this SLE, lupus, and also its tests and all that. Generally, it is not very clear to many about what exactly is happening. So, what is it actually?
Yes, when we are talking about the arthritis, definitely SLE also comes. It is not directly in the arthritis, but the major symptoms of the patient, especially in the beginning, will be the arthritis and the fibromyalgia, muscle pain and joint pain will be the initial symptoms. And for that, when we look into this, doctors usually use for the diagnosis and ANA is looked into. And if the ANA is positive and the patient is symptomatic, then it will be considered as a SLE or systemic lupus erythematosus. But if you are randomly looking into the patients, there may be some patients ANA may be positive, but they may not be symptomatic. But if you are seeing an ANA positive and if at all you are not symptomatic, then we should be careful. We cannot diagnose it as an SLE, but we should be careful that it can be, because there is some reaction. The body is your body is started reacting, because many of this autoimmune reaction, if it is there also, it will become symptomatic only after many years. So that is the time for the correction. I'll give you an example. This is a 46-year-old lady, very young, and 156 centimeters height and 60 kg is her weight. And she's suffering for arthritis. For the last 2 years, she was taking medication for the thyroiditis, and for the arthritis, she's taking Folitrax, that is methotrexate, Folvate, HCQ, and some other medications also. I'm not going into the details, and also pregabalin, that is for the pain relief also. So this patient actually, when we looked into, she was positive for the ANA earlier. But after starting this, when I am seeing her for the last 2 years, she was on arthritis medication, and for the SLE also she was on medication. When I looked into that, her ANA came down to normal. But her AMA, RA factor, and anti-CCP is high. And that is the situation. And uric acid crystals in the urine also. So vitamin deficiencies and HSCRP, ESR, CRP, and all high. So in this patient, what was the result actually? Actually, when she started treatment, actually within 3 months, she was able to come down to 50 kg, and her fat percentage, we are always looking for the fat percentage, lean mass fat mass ratio, and visceral fat. And she was beginning 34.4, and it came down to 29.7. And the visceral fat also came down for 6.5 to 3.5. So by the time, within a month, she was almost symptom free. The only thing, she has some exposure to toxins in her profession. If that is increasing, actually she's in the beauty, cosmetic and beauty section she was working. If there is particular things are exposed, she gets again joint pain and problems comes. So she understood, and we are also advised her in how to manage that also. And she was able to comfortably. Before that, actually was in the stage that she was stopping her professional life itself. but she can manage and she is understood. That is the thing. And in the SLE is also, as SLE or the SLE associated arthritis also, we can control with the lifestyle correction. We may not be able to come out of it completely, but the problems will be there, but we can live a quality life if you are without any medicine. And actually within a month, within I think it took 2 months, because usually this folate tracks and all, it takes some time. Usually in our case, within 3 months, we will be able to come out of this. Slowly we are reducing the medication is slightly for these autoimmune diseases. Very slow withdrawal will be there. But the metabolic problems, because we have, it can be early withdrawal will be possible in most of the cases.
To someone who is watching and thinking whether they should go for a surgery for their joint pain, what is it that you have to say? Because many will be thinking many times when they are considering surgery for joint pain.
For this hip or the knee, that is the most commonly done surgery, hip replacement and the knee replacement. Hip replacement for the fracture, it cannot be, we cannot do anything for the fracture. That is only the matter of the orthopaedician and the hip replacement or whatever, or repair or what. That is the field of the, this is the problem with, or the specialty of the orthopaedician. If it's a fracture, it has to be done accordingly. But for the osteoarthritis point of view, definitely, if you are willing for the lifestyle correction, and you can come out of it. That is my experience. I have given you so many experience with the patient itself. Even with the severe this thing, if you can do the basic exercise and you can take at least a liquid diet. That is, you can, if you are able to provide the optimal nutrition enough for the body, and also the movements, even the joint, it has to, only if you get movement, this nutrition goes into the joint. Even though there is cartilage, doesn't have any blood circulation, but the bone below the cartilage is getting the blood circulation, and from that it is nutrition is going into the synovial fluid, and from there the cartilage is getting the nutrition. That is why the repair is possible. Even the cartilage is cannot be, generally speaking, cartilage cannot be rebuilt, but the composition can be corrected. The repair is possible for the cartilage. It cannot be rebuilt, but it can be repaired. And if the patient is willing, and if the patient is more sicker, the support people is the most important. The patient should be willing, and the support care should be enough. And then we can avoid many of this hip and knee replacement. But then next is the most important, the common is the disc related surgeries. Disc related surgeries, if there is a neurological deficit or neurological symptoms, immediate surgery will be needed. So otherwise the pain and the nerve can be damaged. So don't wait if there is a neurological symptoms, the nerve damage is there, just go for the surgeries. And you can, there will be 24 vertebrae there is 23 discs are there. So you can replace one or two this disc, or can do the correction. You cannot do the 24, all the 24 cannot be corrected. So the problem with the neurology problem can be occur, they correct it. And then after the surgery also, definitely you should consider this lifestyle correction. And improving the muscle attached to it, and also giving the correct nutrition. If you can give the correct nutrition, even the disc can be repaired, and the associated muscles should be strengthened. That can be done only through the optimal or the ideal raw materials for the body, and also the circulation has to be improved with the activity, and that should be done in a proper manner, which is that also very important. If you do heavy weightlifting and such exercises, it can damage, and especially for the disc problems.
With that, we come to the end of today's live. What we most probably can take away is that the joint pains, many in nature, they are necessarily felt at the joints, but the impact there is not only of that immediate joint, but the impact is from the whole body's biology. Sometimes the greatest impact may be the weight of the person. Sometimes it must be the immune reaction or the autoimmune reaction in the person. Sometimes it may be a lack of good circulation. Many a time it may be got to do with the nutritional status of the person, or if you look at it in another way, it may be due to the lack of muscles and muscular strength in that portion and in that person. So this way, though we are talking about the joint in different parts of the body, it has to go and deal with issues that are sometimes far away from that joint. So this is why doctor is emphasizing the importance of, when you have a joint problem, you should see what is the problem, but the solutions may be uh, somewhat elsewhere as well. So you have to look at the whole picture, and then you get a better solution to your joint problem. If you have any concerns or doubts regarding this topic, we would like to take it up in the next live if possible. So please send it over in WhatsApp to the phone number that follows. Thank you.